Hi, I'm Dr. Swati from Radaxis and COBRA, and today we have with us Dr. Ashish Atre, who is the Chief Radiologist at Star Hospitals. Hi, sir. It's an honor to have you here. Sir, what neuroprotocols do you feel perfusion contributes as a key match winner?
As you would know that we do not include perfusion imaging for each and every neurology protocol. But when it comes to evaluation of tumor, it is a must to be included in the protocols. We include it also when we want to differentiate a tumor from a tumor-like lesion or tumor-like looking lesion. It is an included protocol in our routine applications. It also contributes when one wants to differentiate radiation necrosis from tumor recurrence. And we use it as like others for evaluating acute stroke to know the area of penumbra.
What are your mantras for running successful perfusion protocol?
To be frank, no one thing always works, but routinely what we do is to have a clear understanding and a detailed look at the scan which have been done previously. This really helps me because if I find that on an earlier done MRI study, if patient's lesion or tumor is brilliantly enhancing on post-contrast MRI study, I change my perfusion protocol by using a 5 cc pre-perfusion contrast injection, doing a contrast scan followed by perfusion MR. Why I do this is because it is supposed to saturate the leakiness of capillaries, which is commonly seen in high-grade tumors and is sort of known to distort the perfusion data analysis. To prevent this, I use a 5 cc priming with gadolinium and prevent this from happening. So looking at earlier MRs and CT studies is absolutely must. Secondly, I also look at the patient's clinical details as to what we are expecting and whether we are expecting a tumor recurrence or not in an already treated patient. We have to have an expert technicians to run these protocols because mistakes are very often and they are non-correctable. So having an expert technician, a radiologist who is ready to analyze the data on the spot and seeing earlier MR studies to check whether the tumor was enhancing or not is important for deciding the perfusion protocol.
In multi-parametric mapping of brain tumors, how do you feel the capability of post-processing engines match the acquisition platform in Philips ScannerSoul? Comments.
The data acquisition of perfusion MR has become very robust almost in all systems. It is very good on the system which I work, that is Philips 3T-TX system, but there is definite limitations as far as the workstation goes. It is the capabilities of these workstations to analyze the data rapidly and to handle such a huge amount of data in limited span of time. It is still a big question. There are many limitations on this front, and getting various parameters out of these perfusion data is still a big challenge. Second big challenge is the consistency of the results. That is, getting the same numbers if you put the area of interest in the same area. You should get consistent numbers of perfusion values, which according to me still does not happen. So these engines which are supposed to handle this huge amount of data are still not evolved to the extent that I would have liked them to.
Have you made your hands dirty yet with ASL? Comment on its current and future utilities.
We do not use ASL routinely for tumor perfusion evaluation because frankly I don't have my own data to substantiate my results. So we use it as an add-on thing when we are doing contrast enhanced perfusion MR. We just put it as an add-on protocol, but we do not primarily use it to analyze our data or to form our opinion. So my expertise in this field are still limited, and I do not know of anybody who has convincingly demonstrated the utility of this technique as compared to the contrast enhanced perfusion MR.
Lastly, what kind of heights should APPS team reach in order to match the expectations of radiologists and end users and clinicians?
Data acquisition is very good in almost all the systems. especially in the Philips TX system that we are working on. But there are several limitations on the front of data analysis, and generation of color maps is well established, but getting the perfusion indices of RCBV values or mean transit time, etc., is still a big challenge. We do not know how much importance does the arterial input function have on all these parameters. We are using it on a day-to-day basis and analyzing the data and sort of calculating the RCBV indices to assess the tumor grading and also to differentiate radiation necrosis from tumor recurrence. But the validity of this data and the reproducibility is still a big concern. So once this is established on day-to-day basis, that when I draw the ROI in the same region, I get the same perfusion indices. If once that is achieved, I would be more comfortable and more confident in attaching tags to my report. That would be the next thing to do for all these search engines.
Thank you.